Welcome to Minute. Now we are going to study cystic fibrosis. Cystic fibrosis is an autoimmune disorder autosomal it's a congenital disorder. It's a autosomal dominant disorder, and this congenital defect, it actually involves the cystic fibrosis transregulator gene. And this transregulator gene, it happens to present on chromosome number 7. So bottom line कि at the end of the story, जब भी हमारे पास regulator gene नहीं है, we get जो mucus secretions होती हैं, these get thickened due to the faulty channels and faulty combination of sodium chloride and water in the mucus that lead to thick secretions. The mucus, thick mucus secretions. So क्या है? Wherever these secretions are, they get clogged up. So if they are present in the pancreas, that blockage leads to certain clinical manifestations. Same if they are present in the intestines, same if they're present in the respiratory airways. So, other in the case, they get clogged up in the ducts of the pancreas. So pancreatic enzymes are not able to go outside, and pancreatic enzymes are the reason the fats are absorbed and the fat soluble vitamins are absorbed. So if they get clogged up over here, the pancreatic enzymes बाहर ही नहीं जा पा रहे, then that would lead to deficiency or inability to absorb fat soluble vitamins. Which are A, vitamin D, vitamin E and vitamin K. If fat ही absorb नहीं हो रहा, fat soluble vitamin ही absorb नहीं हो रहे, then the stools become bulky, which we call that steatorrhea. Same problem in the pancreas, one side of story. Second side ये है, all the pancreatic enzymes, they are in the ducts, and sometimes they get activated somehow, and they shouldn't get activated within the pancreas. And what they do, they eat up the pancreas, and that leads to acute pancreatitis. And there are repeated episodes sometimes in some patients that lead to chronic pancreatitis in these patients and the complications. And another regarding the pancreas, all the destruction of the pancreas, this happens in different regions, and if the beta cells are involved, that would lead to insulin dependent diabetes mellitus. Just it behaves like type 1 diabetes. So the secretions are clogged up in the pancreas, the pancreatic enzymes are not able to go outside, so the fat soluble vitamins is not absorbed, that leads to steatorrhea. Second side of the story, these clogged up secretions, these clogged up pancreatic enzymes, these get activated, and that lead to acute pancreatitis or repeated episodes that lead to chronic pancreatitis. And this pancreatitis, when the beta cells are involved, that lead to the manifestation just like insulin dependent diabetes mellitus. So if the mucous secretions, these are present in the intestine, that can lead to intestinal obstruction. The patient can come with these complaints, and if they get clogged up in the respiratory airways, then the clogged up secretions, the stasis, that's an excellent environment for bacterial growth, and that leads to repeated chest infections, repeated lower respiratory tract infection, and repeated insult to the lung parenchyma. That leads to bronchiectasis, which is irreversible dilatation of the large airways. So if we write this down, all of the clinical manifestations of, so a patient of cystic fibrosis usually presents with a history of chronic diarrhea with bulky stools, steatorrhea, weight loss, and chronic and the history of repeated admissions for respiratory tract infections, and is also diagnosed with a case of insulin dependent diabetes mellitus. So on examination, a patient was chronic diarrhea, steatorrhea. The malabsorption should be sought out. So on examination, we're going to look at a patient who is emaciated, who has angular stomatitis due to iron deficiency or multivitamins deficiency. Then the beefy tongue or the fisher tongue might be there because of the vitamin B12 deficiency. There might be bleeding gums, or there are purpura or ecchymosis on the skin due to vitamin K deficiency. And then, as we said, the weight would be the less than the ideal weight of the respective age. Then, how we investigate such a patient? The general investigations to look for the consequences of the main disease is we start with the CBC that shows anemia from normocytic to microcytic. Both can happen. Then we go for the serum calcium. Because of the vitamin D is not absorbed, the serum calcium is low. The serum vitamin D levels, these are decreased. Then we go for checking for the chest X-ray that shows congestion, cystic shadows because of the bronchiectasis, and we can confirm this by getting high resolution CT scan chest. That shows that cystic changes or the honeycombing. The patient has history of repeated chest infections. We send the sputum for culture sensitivity and also for acid-fast bacilli. This is usually the work of our patient. These are for the consequences of the main disorder. What is the special investigation, the main investigation to make the diagnosis? Is check for the sweat chloride test. As the secretions become thick, so chloride is less than 60 millimole per liter. And then the genetic investigation, the main, to confirm it, is to check the cystic fibrosis transregulator gene itself on the chromosome 7, the cytogenetic studies. Now we confirm with the diagnosis. How would we treat the patient? Starting with, the patient has this problem with the chronic diarrhea. So first we replenish the losses. So calcium and vitamin D supplementation are provided. These are the vitamin D even supplements. These are present as oils, can be given IM or can be given orally. Then the hematinics are provided, folic acid, iron, vitamin B12. Then we can give patient pancreatic enzymes. And then a good glycemic control. To decrease the incidence of chronic complication of the diabetes by giving insulin. Now, what about the respiratory manifestations? The patient has history of repeated chest infections. So, for the chest infections, we advise the patient for the prompt diagnosis. Whenever he or she gets fever or cough, she should come to the doctor immediately, should promptly treat it at that time, and treatment without any delay should be instituted. Then the patient has bronchiectasis, then the chest physiotherapy regular. Then the mucolytics like N-acetylcysteine. This should be given to the patient. Now there are other treatment modalities present to reduce the exacerbation of the chest infections. So how to reduce the exacerbations? Is to give nebulized human DNAs. Break the mucus plugs, reduce the incidence of respiratory tract infection in a dose of 25 milligram per day. Then another option is to give nebulized tobramycin in the patients in which we suspect to have Pseudomonas infection. Then another option is to give nebulized with hypertonic saline 7%. Another option is we can give oral prophylactic antibiotics like azithromycin 500 milligram thrice weekly. Now, among the new treatment modalities, we also have the gene therapies like the cystic fibrosis translocated gene. Either we have a potentiator or the correctors. So, two drugs that are in the trial that are working in a better way for some people are Evafactor Evacaftor and Vermicaftor. So these are the new treatment modalities. So this is all about cystic fibrosis, the treatment and the management. Thank you very much.